Okay, so the lecture on Chapter 50 includes first trimester pregnancy complications. And just to recap, first trimester dates include the first day of the last menstrual period to weeks 13, to 13 weeks and 6 days. At 14 weeks, that begins the second trimester. So the biggest problem, the most common problem in early pregnancy is first trimester bleeding. Approximately 15% of clinically recognized pregnancies are spontaneously miscarried. You might hear the words spontaneous abortion. That means miscarriage. Don't confuse that with therapeutic abortion. A therapeutic abortion is when somebody goes in and either has a pregnancy surgically or medically removed. So at any rate, 15% of clinically recognized pregnancies are spontaneously miscarried. Most common presentation for complications is vaginal spotting or frank bleeding. Frank bleeding means red blood, not spotting, but actual blood, at nearly 25%. Bleeding is often inconsequential, resulting from implantation of the conceptus into the decidualized endometrium, commonly called implantation bleeding. However, if bleeding is accompanied by severe pain, uterine contractions, or dilated cervix, pregnancy is unlikely to progress. That is most likely a miscarriage in progress. Patients benefit from early transvag examinations to carefully examine uterine cavity, to investigate presence of embryo, fetal heartbeat, yolk sac, or retained products of conception. Not to mention, we can see all of these things up to 1 week earlier when we scan transvaginally compared to when we scan transabdominally. One of the most dangerous things that can happen to cause bleeding is what's called a placental hematoma, which can lead to something called a placental abruption. And what that is when the embryonic placenta, the frondosum, becomes detached from the uterine wall, and that bleeding will then cause a clot hematoma, which then pushes it away even further, and obviously there can be no exchange of nutrients and oxygen and respiration if there is no placenta, and that's an abruption. That is an emergency, and that represents a 50% or greater fetal loss. Okay, so looking more into placental hematomas and placental abruptions. Placental abruption technically is a term that's used after 20 weeks, meaning that the placenta has torn away from the uterine wall. And like we had said before, that is an emergency situation. Oftentimes, this is caused by trauma. I believe it can also be caused by chronic high blood pressure. But this is a picture of it. So you've got the fetus within the amniotic sac. Here's the placenta, and then here's this hemorrhage. This I wanted to show you also reference this picture, even though this is a much earlier pregnancy. What they're showing you is this bleed would be happening kind of all in here. So it has the ability to then leak out. So this patient will present with bleeding. And that is what's termed on here a retroplacental hematoma. Okay, so when it's behind the placenta, it is retroplacental, and if it if it's just one small part, like let's say here, the baby has a much higher chance of surviving than if it detaches the entire placenta, which is then considered an abruption. Okay, this second one here, B, is the scenario that I was discussing over here where it's a marginal placenta, so placental abruption. So the baby at least has this area of placenta still attached, but you've got this hematoma or hemorrhage or bleed, however it's termed, because they're used interchangeably, affecting this portion of the placenta and then up here to the fundus. And again, this can come out and cause bleeding in the patient. This here is also termed a subchorionic hemorrhage when it's behind the chorion. It will be termed a subchorionic hematoma or a subchorionic hemorrhage between the chorion and the uterine wall. Okay, so it can also be at the margin of the placenta. And this one here is under the amnion. As you can see, this bleeding is between the amnion and the placenta. And here it's between the amnion and the chorion. So this patient would not present with any bleeding. Just as we saw on that last slide, some placental hematomas are not going to cause bleeding or spotting because they are contained within the chorionic sac, and there's no communication with the endometrium. So if a patient comes in with trauma, let's say they've been in a car accident, they want you to evaluate. The patient may say they're not bleeding, but that does not mean that there's not a detachment or a bleed somewhere. So you have to look very carefully at those patients. So this is the one that's most important right now. Subchorionic hemorrhage. Most common occurrence of bleeding in the first trimester is from the subchorionic hemorrhage. Low pressure bleed results from the process of implantation of fertilized ovum into endometrial cavity and myometrium wall. Hemorrhage found between the myometrium and the margins of the gestational sac. May or may not be associated with the placenta depending on where the bleed occurred. Clinical findings may include bleeding, spotting, uterine cramping. If hemorrhage becomes large enough, it can lead to a spontaneous abortion or miscarriage. So here's an example of a subchorionic hematoma. You can see the embryo here, and you can see in this double decidual ring, this is the chorion, the capsule, and the bleeding is happening here between the chorion and the uterine wall. So this is going to present bleeding to the patient. This is relatively small. I mean, it looks big, but if this bleed is more than 50% of the perimeter of the sac, that's much more hazardous to the pregnancy, but a small one like this most likely will stop bleeding, reabsorb, and the baby will be fine. But I gotta say, when I used to do first trimester ultrasounds, it was more common than not to see some sort of a subchorionic bleed, at least a little one. They're very, very common. Here's another one. Gestational sac, placenta, chorion, blood. This blood looks a little different from the other slide because this blood is beginning to clot. So that's just an example to show that blood can take on different appearances depending on the age of the bleed. Fresh blood is going to be anechoic. Blood that's starting to clot is going to become more echogenic. And then once the blood fibrin breaks down and becomes liquidy again, it's going to be anechoic again. So sometimes it's really difficult to say how old a bleed is. If it's anechoic, you don't know whether it's fresh or whether it's old. So as we just talked about, early bleed may appear slightly echogenic as the red blood cells actively fill the area of hemorrhage. With time, it's going to become more anechoic and may be seen between the uterine wall and the fetal membrane. Patients may present with active vaginal bleeding and subchorionic bleed, easily seen by ultrasound adjacent to the gestational sac. Well, I would say early bleed may be anechoic, then become echogenic, and then become anechoic again. Okay, here's another one. This is the gestational sac. Here is a blood clot, and it is outside of the chorion. It's behind the chorion. So this is behind the chorion, a subchorionic hemorrhage. Okay, the intrauterine sac. If a patient presents with a positive pregnancy test, the uterus appears normal, and the endometrial complex shows no sign of gestational sac, differential diagnosis would include a very early pregnancy, a non-developing pregnancy, or a possible ectopic. That's why it's important to have a quantitative beta HCG if it's available. If the quant is above, I never finished this slide, but if it's above the discriminatory zone, which we'll get to, and there's still no sac, then that's when you have to look at an ectopic. Okay, discriminatory zone. That is when the discriminatory zone is the serum beta HCG level, meaning a blood test, is above which a normal gestational sac should reliably be visualized inside the uterus using transvaginal ultrasound. So there's some number that the facility will use as a threshold. They'll say, if this patient's quant comes back at 2000, let's say, and there's no gestational sac seen, that is very highly suspicious for an ectopic pregnancy. However, if it's below that discriminatory zone, it just may be too early to see. So they have to have a threshold to know when you should reliably be able to visualize a sac. So the current consensus is 1,500. Some studies suggest that that number should be higher, like 3,000 or 3,500, especially to avoid false positive diagnosis and ectopic pregnancy. So whatever the discriminatory zone is at your facility, that's what you're going to use. I think most places are using something like 2,000 right now, but I can find out more about that. But anyway, what it means is that above the zone, if it's greater than 3,500 or 2,000 or whatever number they're using, and you have an empty uterus, it's highly suggestive of an ectopic pregnancy. Below the zone, plus an empty uterus, often classifies as a pregnancy of unknown location. necessitating repeat testing in 48 hours, testing the HCG levels to determine if levels are rising as expected. All right, the sac should grow at approximately 1 millimeter a day in the first trimester. A yolk sac should be visualized transvaginally when the gestational sac mean sac diameter reaches 8 millimeters in size. And just to go back over how to get the mean sac diameter, it's length plus width plus depth divided by 3. And if that number is 8 millimeters or more, you should see a yolk sac. Okay? The embryo should be visible when that mean sac diameter is greater than 16 millimeters. Normal embryo grows at the rate of 1 millimeter a day also. So the sac should be growing along with the embryo. So if you have this tiny little sac and an almost same size embryo, that is not normal. Cardiac activity visible between 5.5 to 6.5 weeks. And I think to be specific, your book says 35 to 36 days. In case of pregnancy loss, serial HCG levels demonstrate successive decline. As the pregnancy is being expelled from the body, HCG levels should be declining. If HCG levels are not declining, that tells us that there's probably some products of conception, retained products of conception left in the uterus, and that necessitates surgery to remove, like a D&C, to remove those remnants of the pregnancy. Caution should be taken when positive pregnancy test and empty uterus seen. Possibility that early normal intrauterine pregnancy between 3 and 5 weeks of gestation may be present. That's why we need a quant. Remember, we're looking for that number to be above or below the discriminatory zone. And serial HCG levels should always be obtained. If the endometrium is abnormally thick or irregularly echogenic, differential diagnoses include intrauterine blood, retained products of conception after an incomplete spontaneous abortion. We'll go over that again. Decidual reaction associated with ectopic pregnancy, decidual changes resulting from early but not yet visible intrauterine pregnancy. Incomplete spontaneous abortion may show several sonographic findings ranging from intact gestational sac with non-viable embryo to collapsed gestational sac, grossly misshapen. Applying the Society of Radiologists criteria that comes from the New England Journal of Medicine 2013, pregnancy failure can be definitively stated when the embryo is 7 millimeters or greater without a heartbeat, or if the mean sac diameter is 25 millimeters but no embryo is visible. Okay, here are some types of miscarriage, spontaneous miscarriage slash also known as spontaneous abortion. I would caution you in using the term abortion It is a trigger word for some people. So what the preferred terminology is early pregnancy loss. Okay. There's missed abortions, which means there's no vaginal bleeding, there's a closed cervical os, no fetal cardiac activity, or an empty sac. That means that this embryo is not viable, but it's still in the uterus. Then there's what's called a threatened abortion. That means that the patient is bleeding and cramping, the cervix is closed, and there is fetal cardiac activity. So this is not a good scenario for the patient. Many times this ends in miscarriage. One step beyond that is inevitable pregnancy loss. This is when there's vaginal bleeding and cramping, there's a rupture of the membranes, dilated cervical os, products of conception may be seen or felt at or above the cervical os. So this is a miscarriage in progress. This one is known as an incomplete miscarriage or incomplete abortion, where there's vaginal bleeding and cramping, dilated cervical os, some products of conception were expelled, and some remain. What remains is known as retained products of conception. And if these are not expelled quickly, that's going to be a situation where she needs a D&C because it can create infection. And then there's complete spontaneous abortion or complete pregnancy loss, where there's been bleeding, there's closed cervical os, products of conception are completely expelled. Okay, this is an example of an incomplete abortion with retained products of conception. You've got heterogeneous and thick endometrium, but it is isoechoic, so it could be a little difficult to see sometimes. You have to put color on. Retained products of conception will be hypervascular. You can see here again, it's a little bit subtle, difficult to see. Sonographic signs of retained products may be subtle, thickened endometrium of greater than 8 millimeters, increased vascularization of endometrial complex, and color Doppler is strongly predictive. So if you have a thickened endometrium, hypervascular endometrium, you most likely have retained products. All right, the presence of viable embryonic parts, gestational sac, embryonic disc, obvious evidence of retained products of conception, pretty likely also spontaneous abortion. Sometimes difficult to distinguish retained products of conception with blood clots. So how can you figure that one out? I'll wait for someone to tell me. You can tell me when I see you again. Quantitative HCG levels that do not decline normally. Thickened endometrium and increased vascular flow will be discriminating evidence for retained products. Okay, here's an example of a spontaneous abortion. Notice the irregular sac shape, and you've got all this extra thickening and edema in here. Another example of retained products. Okay, gestational sac without an embryo or yolk sac may present one of three conditions. It may just be too early, might be a normal pregnancy, less than 5 weeks. It may be an abnormal intrauterine pregnancy, or it may be a pseudogestational sac with in the patient with ectopic pregnancy. How would we know if it's just too early? Got to get that quant. Okay. This gestational sac, kind of oddly shaped. There's a mean sac diameter of 27 millimeters, no fetal pole, no cardiac activity. Obviously, if there's no fetal pole, this is what we call an anembryonic pregnancy, also known as a blighted ovum. It means that the gestational sac formed, but there's no embryo and no yolk sac, and there's not going to be one. It's an abnormal pregnancy. So, criteria for an abnormal sac. Gestational sac should be imaged consistently by both transabdominal and transvaginal sonography when its mean diameter is 5 millimeters. Corresponds to a gestational age of 4 to 5 weeks. So you have to have follow-up. Sequential scanning can document appropriate interval growth of 1 millimeter a day. So in 1 week, that mean diameter should increase appropriately. Sac of appropriate growth indicates abnormal sac. Lack of appropriate growth indicates abnormal sac. So if it's not growing properly, it's probably an abnormal pregnancy. Transvaginal sonography is ideal to image early gestational sac. When the gestational sac measures 8 millimeters or greater, a definitive yolk should be demonstrated. Yolk sac grows 0.1 millimeters of the mean sac diameter growth up to 15 millimeters. So when the gestational sac measures 25 millimeters, an embryo with cardiac activity must be seen. If not, that is diagnostic of an early pregnancy loss. Okay, back to blighted ovum or anamnionic pregnancy. Trophoblastic tissue may continue to proliferate despite failed embryonic growth. Who remembers what trophoblastic tissue is? These are the cells that make up the placenta. Gestational sac will continue to grow, and HCG levels may continue to rise, but not at a rapid rate. Typical sonographic appearance of an anamniotic pregnancy is a large empty gestational sac. Does not demonstrate a yolk sac, amnion, or embryo. Mean sac diameter increases by 1.13 millimeters a day in normal gestation. Growth rate of abnormal sac only 0.7 millimeters a day. You do not have to commit these numbers to memory. Just know that your mean sac diameter is supposed to increase 1 millimeter a day. Okay, here's another example of a blighted ovum, also known as an anembryonic pregnancy. In subsequent repeat studies, you should evaluate the growth size of the sac, the presence of a yolk sac, the development of the embryo, and the presence or absence of any cardiac activity. And this is development of the embryo if there is one, which there shouldn't be because this is an embryonic pregnancy. So obviously, if there's an embryo, it's not this, something different. Some of the sonographic findings of gestational sacs that are associated with abnormal intrauterine pregnancies are a embryo that is greater than 5 millimeters or greater without cardiac motion, or no cardiac motion in an embryo after 6.5 weeks pregnancy. And if you see a large yolk sac or amnion without a visible embryo, or a calcified yolk sac, those are all findings of an abnormal intrauterine pregnancy and most likely a early pregnancy loss. Other findings would be a large gestational sac with a mean sac diameter greater than 18 millimeters, lacking a viable embryo, or greater than 8 millimeters, lacking a visible yolk sac. If it has an irregular or misshapen gestational sac, or if the position is anywhere but in the fundus, including up in the cornua, lower uterine segment, or especially hourglassing through the cervical os, because that means it's exiting. This would be ectopic anyway. So definitely abnormal. So some other sonographic findings of abnormal gestational sacs, which are associated with abnormal IUPs. This trophoblastic reaction is another name for decidual reaction. If it is irregular, like here, you don't have that double decidual ring like you do in a normal early intrauterine pregnancy. If it's just a thin ring, like less than 2 millimeters, or it's in a regular shape, like this one is elongated. This is what's called a pseudosac, which is basically just a collection of fluid within the myometrium that sometimes comes along with an ectopic pregnancy. If the growth of the gestational sac is less than 0.6 millimeters a day, or if there is absent embryonic growth, or if there's a discrepancy between the sac size and HCG levels. So let's say that you're looking at one of those charts and you know from the mean sac size that this pregnancy is roughly 8 weeks, and you look at that chart and it's way below, then obviously there's something wrong. Okay, on to the next topic, which is called gestational trophoblastic disease. So trophoblastic disease is the abnormal proliferation of trophoblastic cells, and they are the cells that normally form the placenta. And it's due to faulty fertilization. The term trophoblastic disease represents a spectrum of disease from relatively benign form, called a hydatidiform mole, and they come in partial, complete, and coexistent varieties, to a more malignant form called an invasive mole, or even something called a choriocarcinoma. We're going to talk about each one of those. So types of hydatidiform moles, that's how you pronounce that, hydatidiform moles. There's a partial mole, and it's a form of gestational trophoblastic disease in which there is an abnormal trophoblastic proliferation with an abnormal placenta alongside embryonic or fetal tissue that is non-viable. A concurrent mole refers to a twin gestation in which one conceptus is a molar pregnancy, usually a complete mole, and the other is a separate, potentially normal fetus with its own placenta. Okay, so the sonographic appearance of a molar pregnancy has been described as a snowstorm appearance or a cluster of grapes. And what that is these are actually cystic spaces representing hydropic chorionic villi. So these are fluid-filled little spaces here. A complete mole, which this is a complete mole, is a form of the disease characterized by diffuse abnormal trophoblastic proliferation with no embryo, no fetus, no normal placental tissue, and sonographically moderately echogenic soft tissue mass filling the uterine cavity, marked with the small cystic spaces. The clinical hallmark of gestational trophoblastic disease is vaginal bleeding in the early first or early second trimester. Serum levels of HCG will be dramatically elevated, often greater than 100,000 units. And if you remember when we were talking about what cells make the HCG in a normal pregnancy, we said it was those trophoblastic cells. So it would make sense if you have a proliferation of the cells that they would be cranking out a whole bunch of HCG. Patients may also experience symptoms of hyperemesis, which is severe vomiting, or preeclampsia, which is high blood pressure, and maternal serum alpha-fetoprotein levels will be low, notably low in pregnancies complicated by hydatidiform moles. Here is an example of a molar partial mole here and here. Now, it doesn't tell us if this is a twin pregnancy. It looks like a viable pregnancy. It does not look like sometimes you can tell by the collapsed bones and so forth. So this may just be a partial molar mass. Here's another one with a molar placenta. This is a complete hydatidiform mole, and transverse transvaginal view shows an enlarged uterus, distension of the uterine cavity by this echogenic material with the little cystic spaces, the bunch of grapes appearance or snowstorm appearance, and there's increased vascularity, as you can see here. Another one, high velocity flow through the abnormal tissue. Okay, an invasive mole is when the tissue starts to invade the myometrium. So it says here, the sagittal view of uterus with transvaginal sonography and powered Doppler angiography demonstrating increased vascularity, trophoblastic proliferation. There is deep myometrial invasion, only 1.8 millimeters from the posterior uterine serosa. So this outside lining of the uterus, it's 1.8 millimeters away, indicating the presence of an invasive molar pregnancy. Arrows show the distance between the invasive molar pregnancy and the serosa, so you can kind of see that here. The most severe form of the trophoblastic disease is called a choriocarcinoma, and this is a malignant tumor that comes from trophoblastic cells of the placenta, and typically following a molar pregnancy. So this example here is it's a postmolar choriocarcinoma after an interval of 7 years. So this woman had a baby, had a molar pregnancy, and 7 years later, they found that it developed into this choriocarcinoma. It says that they are typically, there's a 90% survival rate if they catch it early, which is pretty impressive. But anyway, it'll present with abnormal uterine bleeding, high HCG levels. Unfortunately, it can metastasize. It metastasizes early to the lungs, and they can treat it with chemo or methotrexate, which is a medication that they give to stop the trophoblastic cells from growing. So I think the slides already went over this, but just to recap, on transvaginal sonography, abnormal appearing choriodecidual or trophoblastic reaction consists of distorted sac shape, thin or weakly echogenic or irregular decidual reaction, thin walls. The rings will have thin walls. Absence of a double decidual sac, and mean sac diameter exceeds 10 millimeters, so it will be large. Usually no sign of viable embryo, and early developing placenta exhibits multiple abnormal trophoblastic changes. Sonographic examination may reveal a uterus larger in size than dates, so large for dates, they call that. Filled with heterogeneous complex pattern, that snowstorm or bunch of grapes pattern. Bilateral adnexal fullness may represent ovarian enlargement of thecalutean cysts. A partial mole on sonogram has identifiable placenta, placental tissue grossly enlarged and engorged with cystic spaces, as we saw on that earlier slide. Embryo or embryonic tissue may be identified. Often embryo is abnormal and aborted in the first trimester, and in later stages of pregnancy greater than 12 weeks, careful analysis should be made to look for structural defects. Choriocarcinomas is the malignant form and occurs in 2 to 3% of molar pregnancies. The tumor is fast growing, commonly metastasizes to lungs, liver, brain. Clinical symptoms include vaginal bleeding, in addition to dyspnea, abdominal pain, and neurologic symptoms, depending on where the mets has spread to. Okay, on to a different topic now. We're on to abnormal or absent cardiac activity. Identifying an IUP with or without cardiac activity is first conclusive sonographic sign of viability. So first trimester, early pregnancy, it is all about the heartbeat. If you see a heartbeat, generally it's a viable pregnancy. With transvaginal sonography, a living embryo should be detected by 46 menstrual days, meaning from the first day of the last period, within 46 days, you should be seeing a living embryo. And more than one sonogram may be necessary to establish a normal pregnancy, because people like to come in super early, and sometimes it's too early and they have to have a follow-up. Absence of cardiac activity in the first trimester is the most critical sign for viability of pregnancy. Heart tube is formed between 3.5 and 5 weeks of conception. If the embryo is visible by sonography, but cardiac activity cannot be documented, there is a poor prognosis. On transvaginal sonography, when the crown rump length measures 4 millimeters, embryo should demonstrate cardiac function. Generally, if any doubt exists in measurement, patient re-examined in several days for presence of cardiac activity. Images should be made with the highest possible frequency to image with greatest accuracy. The transducer should be very carefully swept through the gestational sac to image the embryo, cardiac motion, and yolk sac. Once cardiac activity is seen, M mode should be used to record the actual heart rate. Notice it says M mode. We never put pulse wave Doppler on a little gestational sac. It's just too much energy for that little structure. So here's an example of using M mode to get a heart rate. And then you measure either 1 or 2, depending on the settings on the machine, either 1 repeating pattern or 2 to get the heart rate. So the SRU, or the Society of Radiologic, I forget what this stands for, but some radiologic society criteria states that pregnancy failure is diagnosed when a crown rump length of 7 millimeters without cardiac function. So those other numbers that we learned, should have a heart rate by the time it's 4 millimeters. Those are suggestive of pregnancy loss, but 7 millimeters without cardiac function is diagnostic of cardiac loss. Okay, so bradycardia and tachycardia. If you remember from your A&P course, bradycardia is a slow heartbeat and tachycardia is a fast heartbeat. So embryonic cardiac rates of less than 90 beats per minute at any gestational age within the first trimester is shown to have a poor prognostic finding. Fetuses with a heart rate of greater than 170 show signs of tachycardia. So less than 90 is Brady, greater than 170 is tachy, which may lead to heart failure and fetal high drops. And high drops, the definition of high drops is a fluid collection in more than 2 places within the fetus. So a pleural effusion, a pericardial effusion, ascites, or there's others too, but that's just some examples. So about embryonic oligohydramnios and growth restriction. Growth delay and oligo within the first trimester have poor outcomes. A gestational sac that has less than 5, let me say that again. A gestational sac that is less than 5 millimeters larger than the crown rump length is often termed small gestational sac or small sac syndrome, and it is associated with high risk of early pregnancy loss. Embryonic oligo may be suspected and demise is highly probable. So what this is saying is that the gestational sac should be at least 5 millimeters larger than the crown rump length, or the baby won't have enough room to grow, and that's growth restriction. Embryonic growth restriction can be determined only by relative sonographic dating, either by reliable menstrual history or by growth delay of the embryo or gestational sac in relation to serial sonograms. So we know how much the embryo should be growing per day, and we know how much the sac should be growing per day, and we know roughly how large a crown rump length should be given reliable menstrual dates. So if those aren't lining up, then we can suspect growth restriction. And it's usually due to chromosomal abnormalities such as triploidy, which we will learn about, have an associated, and they have been associated with embryonic growth restriction and embryonic oligohydramnios. For yolk sac evaluation, the expected yolk sac grows 0.3 millimeters a day. So within 3 and a little bit days, it should grow 1 millimeter, but it should not grow past 5.5 millimeters between 5 and 10 weeks gestation. If it is beyond 5.6 millimeters or greater, has been shown for an increased risk of spontaneous pregnancy loss. If the yolk sac is abnormal in appearance, too large for the gestational age, misshapen, highly echogenic, as in calcified or like bone, the patient should be evaluated for early pregnancy failure. If cardiac activity is present, the pregnancy should be followed carefully with ultrasound as the embryo may continue to grow. So to evaluate the amnion, the best way to visualize it is early and with transvaginal sonography between the 5th and 7th week. And you get something called the early on, like 5 weeks, you get this double bleb sign. It's 2 concentric rings. The one with the fetal pole inside is going to be the amnion, and the one next to it is going to be the yolk sac. Anyway, they should be side by side. The amnion should appear as the thinner of the two, and the amniotic disc lies between the amnion and the yolk sac. So abnormal development is suggested when the amnion becomes very easy to see, or if the thickness and echogenicity approach that of the yolk sac. It should be thin and wispy. The mean sac diameter should be approximately equal to the crown rump length, and pregnancy exhibiting a mean sac diameter of greater than 25 millimeters without an embryo is consistent with an embryonic or failed pregnancy. Not speaking about the amniotic sac, we're talking about the gestational sac here. Probably not a good place for them to have put this blurb, but just as a reminder. Ectopic pregnancy is one of the most emergent diagnoses made with ultrasound. If a pregnancy is located outside of the central fundal location of the uterus, it is considered ectopic. Approximately 10% of maternal deaths are related to ectopic pregnancy. Associated risk factors are a rise in the incidence of pelvic infections or PID, the use of IUDs, fallopian tube surgeries, infertility treatments, and a history of previous ectopic. Clinical findings of pain are nonspecific and may vary. Classic clinical findings associated with ectopic pregnancy are vaginal bleeding, empty uterus, positive pregnancy test, and the presence of an adnexal mass. Usually occurs within the fallopian tubes in 95% of the cases. Other sites, such as ovary, broad ligament, peritoneum, cervix, and cornua, account for the remaining cases. With ectopic pregnancy found in the interstitial portion of the fallopian tube near the cornua, there is an increased risk for massive hemorrhage with rupture that may lead to hysterectomy or even death. You guys remember this, right? So outside of the uterus tubes, like this whole pelvic area is considered peritoneal or abdominal. Ovarian, tubal, with the most common place in the tube being the ampulla. Isthmic or interstitial is kind of over here, but they didn't show it. Cervical can also be in a C-section scar. or just low, just in the lower uterine segment. Okay, I'm sure you've heard the term beta HCG. What beta HCG is a subunit of HCG, and it's what is detected in the maternal blood when a quant or a quantitative level is taken for evaluation. So that level is going to come back. There's a number that's going to come back, and there's the WHO, World Health Organization, has decided on a threshold. A lot of facilities are using 1 to 2,000. Some of them are using other values. It's whatever your facility is using, that's the number you're going to go by. But basically, in a nutshell, what that means is that if the patient's quant comes back above the threshold and there is no intrauterine pregnancy seen, then you have to suspect an ectopic pregnancy, especially if there is an adnexal mass and there's pain or bleeding. It's crucial that the sonographer understands which HCG assay, meaning what discriminatory zone your particular institution or lab is using. This is what I was saying, that you need to know your facility's threshold. That's their assay calibration that they're using, that is set by that, was it the international standard, the IRP. Quantification of HCG directly correlated with gestational age throughout the first trimester. But as you know, those numbers, as we looked at that chart, those numbers vary significantly from the lowest normal to the highest normal, and a lot of the weeks overlap. Generally, the first IRP has HCG quantities double that of the second IRP. So what they did is they made the second IRP threshold lower than the first. So just know your facility's number is what that boils down to, the discriminatory number. Using transvag techniques, HCG discriminatory level in detecting IUP has been shown to be 800 to 1,000 based on the second international standard, or 1,000 to 2,000 based on the first international standard. I think that I was kind of researching this, like, how would you know if you were asked a question on your boards? And what I found out is that, generally speaking, tests are going to be based on this first IRP value. So if you're asked about it, what is the discriminatory level for HCG, I would go with this, 1 to 2,000 international units per liter. I think that's what that means. If the discriminatory levels of beta HCG meet or surpass and no intrauterine gestational sac is seen, ectopic should be suspected, as we already said in that last slide. Does not produce, okay, ectopic pregnancies do not produce HCG at normal levels. Normal HCG levels double every 2 days. I will get back to this because we read earlier that it doubles every 3.5 days. So which is it, every 2 days or every 3.5 days? Well, stick a pin in that. I will come back to it. So they don't, you know, come back at normal levels. So what do they come back as? If anybody remembers, they're less than. They are lower than normal because in your fallopian tubes, you do not have the receptors to pick up the HCG. It's not that it's not being produced by the trophoblastic cells. It's that there are not receptors in the tubes to detect it. So 90% of ectopic gestations are not viable. I thought it would have been more than that. I'm surprised that 10% are. May not reflect the typical correlation between gestational age and HCG levels. Well, yeah, we already said that. It's going to be lower. Okay, getting back to the topic of doubling rates. There's the reason that you're given sometimes a reference says every 2 days and sometimes it says every 3.5 days is because it depends on the gestational age. Early in pregnancy, between 1 and 4 weeks, doubling occurs more rapidly, every 2 to 3 days. Later in the first trimester, the doubling time increases to between 3 and 4 days. Peaks and decline, levels peak around 8 to 11 weeks and then decrease as the placenta takes over. As you can imagine, this is not a strict rule. It is a guideline. A doubling time outside the average doesn't always mean a problem, but slower rises, less than 35% in 2 days, can raise concern for miscarriage or ectopic. So if they're way outside of what's expected, then it raises concern. To put it in the medical context, HCG testing is used to monitor pregnancy, but ultrasound is crucial for definitive diagnosis, as HCG patterns alone are not enough. So what can cause the slower or faster rates? We already learned about this, but just to say it again, a slower rise or fall may indicate a problem like miscarriage or ectopic pregnancy, though some normal pregnancies do show this pattern. An extremely fast rise can mean multiple pregnancies or a molar pregnancy. So an ectopic pregnancy may have a similar appearance to an early IUP. In non-emergent cases, serial beta HCG levels preferred because trending of levels would demonstrate continuing pregnancy if HCG levels rise normally. Falling HCG levels may indicate missed or incomplete abortion. And what's another name for that? Miscarriage. I want to get back to this. May have a similar appearance to an early IUP. I suppose that could be true if it were in, maybe within the uterus, but just not fundal in location, or perhaps there is a pseudogestational sac that may trick you into thinking that it's just a really early gestational sac. So in this case, we are relying on these quants to give us a clue. All right, so this is a little classic view, classic appearance where you have the uterus over here, and then in the adnexa, you've got this big mass. You don't necessarily see a yolk sac or a fetal pole. A lot of times you're just seeing a mass, and you may see some mucky fluid posteriorly, but not always. And then this hypervascularity around the periphery is called a ring of fire. Also in a corpus luteum cyst, you may see this, but you could see it in an ectopic as well. Most important finding when scanning for ectopic pregnancy is to determine if the normal intrauterine gestation, if there is a normal intrauterine gestation, which reduces but does not eliminate the probability of an ectopic, because remember, there is such a thing as heterotopic pregnancy, which you have one IUP and one ectopic. If the uterine cavity is empty and there is an adnexal mass present, and as many as 20% of patients with ectopic pregnancies demonstrate intrauterine sac-like structure known as a pseudogestational sac. So your here's your ding 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 if you have a positive pregnancy test, an empty uterine cavity, and an adnexal mass. It's time to get this patient to the ER. Okay, so here's some images. A mass in the left adnexal area separate from the uterus. So this is showing us an empty endometrial. There's nothing in the uterus here. And then we've got the right adnexa over here, and then we've got the, okay, this slide is whack, you guys, and this is what I've been putting up with this whole darn presentation. So this is not the left, this is the right, and I will add my own commentary here. If you see something like this and you're like, okay, here's, I think, what is the ovary, but then there's this other thing and I don't know what's what, and you're getting nervous because this will scare the heck out of you. Actually, over here is a little bit better picture. This is obviously an ovary here, and then there's this thing here. I had a radiologist tell me with a trans vag probe, you point, to this area here and you push gently, you apply pressure. And what you want to see is these two structures separating. You want to see this maybe headed to the right and this headed to the left. If they stay together, then it's one structure. But if they separate, then it's two separate structures, and one of them is probably an ectopic. Okay, here's some more. This is that pseudogestational sac, and this is a could trick you and look like a double decidual reaction, but it's actually not. It's just a little fluid collection in the middle of an echogenic endometrial stripe. And then you have this over here, which we can start to see a little yolk sac and probably a fetal pole there if we were to put color on it. And yeah, so here you go. Here's right ovary, uterus, and here's your ectopic. This is enough to put the fear of God in you when you're a new tech and you're asked to evaluate someone for an ectopic and you're not 100% sure what you're looking for. So try and get very familiar with this. Okay, so this is a little closer up of that ectopic. And this to me looks like ovarian tissue. And then you have this. So this would be one of those, this would be nice to illustrate with pressure from the probe to see if they separate, to show that they separate. Because you got to realize the radiologist is going to want to know for absolute sure if they're going to call this an ectopic, because the patient's going to get wheeled down to the OR, most likely. And, we don't want to send somebody to the OR needlessly. So do everything you can to prove it is an ectopic. And by the way, look how low the scale is set. That's interesting, right? So apply the pressure, see if these structures separate, and that would be really great to prove or disprove an ectopic. So in this ectopic, obviously, they were able to see a fetal pole with cardiac activity, and they took a They took a measurement and they found that this fetal heart rate is 108 beats per minute, which is nice and healthy. Unfortunate that it's an ectopic. Alrighty, so sonographic findings in ectopic pregnancy. Pseudogestational sacs do not contain either living embryo or yolk sac. They are centrally located within the endometrial canal, unlike barogestational sac, which is eccentrically placed. Eccentrically means off center, by the way, just in case you didn't know. So these are going to be right smack in the center, these pseudogestational sacs, and they're just going to be fluid collections. Homogeneous level echoes are commonly observed in pseudogestational sacs, unlike normal gestational sacs, which should be anechoic. The presence of a yolk sac positively indicates intrauterine gestation. So once you see that yolk sac, you're golden. Although that does not necessarily exclude the possibility of an ectopic. But it does prove an IUP. So examining the adnexa sonographically is critical for the evaluation of an ectopic. Identification of a live embryo within the adnexa is the most specific sign of an ectopic gestation, and only about 10% of live ectopic pregnancies identified using transabdominal sonography, which means that you really need to use your TV probe. This patient has free fluid with some echoes in it, and there's free fluid here as well. That is a telltale sign of an ectopic, to have a mass with free fluid, and especially if it's got echoes in it. Identification of an extrauterine sac within the adnexa is one of the most frequent findings of ectopic pregnancy, even if it doesn't have a fetal pole. If you're seeing an extrauterine sac, you may be confused. Are you looking at an ovary with a corpus luteum? Sometimes it can be really nerve-wracking, and that's when that showing that it is separate from the ovary trick with the probe can save you. So it says, say, extrauterine gestational sacs often demonstrate thick echogenic rings separate from the ovary, which represents trophoblastic tissue or chorionic villi, and the possibility that embryo or yolk sac will be seen, but not always. Color flow imaging and Doppler waveforms may also help diagnose extrauterine gestational sacs. They will have a very low resistance waveform. One study reported color flow detection in and around 95 of 106 ectopic gestations with Doppler resistive index of 0.4. Adnexal mass with ectopic pregnancy. Continuing risk of ectopic pregnancy can be greater than 90% when an intrauterine gestation is absent and there is a corresponding adnexal mass. Complex adnexal mass, aside from extrauterine gestational sac, often represent a hematoma within the peritoneal cavity. So it could be a blood clot, usually contained within the fallopian tube, which is hematosalpinx, or the broad ligament. Okay. So this looks like an ectopic here. Now, again, we can, don't forget, you can use these iliac veins or iliac vessels to help with identification of where the ovary should be. Remember, these should be anterior to the iliac vessels. Studies have correlated increased risk of ectopic pregnancy with moderate to large quantities of free intraperitoneal fluid and associated mass. So remember this from when I think we learned about this back in our short little ectopic unit that we did in GYN, was that the biggest sign of an ectopic pregnancy is an adnexal mass with associated free fluid. So when fluid is present, sonographers should also look at abdominal gutters, such as the Morrison's pouch, right and left upper quadrants, to evaluate the extent of volume of fluid present. So if you go up to Morrison's pouch and there's fluid, and then you go over on the left side and you're looking up there around the spleen and you're seeing fluid, this patient has a lot of blood. Interstitial pregnancy or cornual pregnancy is potentially the most life-threatening of all ectopic gestations. And the location of this ectopic is in a segment of the fallopian tube that enters the uterus. And if you remember, the reason that this is so life-threatening is because there's hardly any myometrium surrounding the pregnancy. So as the pregnancy grows, that uterus is going to rupture. So within an interstitial pregnancy, the site involves parauterine and myometrial vasculature, creating life-threatening hemorrhage when rupture occurs. Interstitial pregnancies have been reported to occur in approximately 2% of all ectopic pregnancies. Sonographic identification of interstitial ectopic pregnancy is difficult, described as eccentrically placed gestational sac within the uterus. Incomplete myometrial mantle surrounding the sac. That's what I was saying. There's not enough myometrium all around to prevent that rupture from happening. And then because it's a highly vascularized area, the patient can bleed out. So this is an interstitial pregnancy. This is a cervical pregnancy. And this one is also very dangerous, has a very high risk for having a complete hysterectomy. So this is a heterotopic pregnancy where you have your IUP eccentrically located within the endometrium, and then you have we have one here in the cornua. That is highly unfortunate. Okay, cervical pregnancies. Cervical ectopic pregnancies have an increased risk of complete hysterectomy because of uncontrolled bleeding caused by the increased vascularity of the cervix. You see it way down low like that. Okay, so diagnosis of embryonic abnormalities in the first trimester. We're not going to go crazy with this because we're going to get into this more when we talk about when we start talking about chromosomal abnormalities. But there's a test that can be done between 11 and 13 weeks, 6 days, not 14 weeks, because that starts the second trimester. When you're looking at the thickness of subcutaneous lucency at the back of the neck. So you're looking at this fluid at the back of the neck, and you want to measure its thickness. So you have to make sure that you are measuring between the back of the neck and the skin line and not the skin line and the amniotic sac. That's why this image has to be blown up. There's actually criteria for this. And I should have pulled it up, but I didn't. But it has to be, you have to see, I think, like the tip of the nose. There's certain criteria for this to be accepted as an official measurement. But this is, anyway, this is the idea. And what is that number that it's not supposed to be over? Does anyone know? That number should not be over 3 millimeters, which is 4.4 millimeters here. And this one here, this bubble, that's called a cystic hygroma. That's a little bit different than this. This is a different abnormality. So with the nuchal translucency, increased nuchal translucency may be found with trisomies 13, 18, 21, which we will learn about later. Fetuses with cardiac defects and other genetic syndromes. High-resolution transducers have lowered the threshold of when we are able to visualize these anomalies sonographically. So we're starting to be able to see them earlier now. Nuchal translucency measurement combined with biochemical markers such as free beta HCG and pregnancy-associated plasma protein, or PAP-A, to assist for risk of aneuploidy. And aneuploidy is just a word that means having chromosomal abnormalities. Fetuses must be between 11 weeks and 13 weeks, 6 days. Oh boy. Crown month, which the other one said 14 weeks, so disregard that. Crown rump length must be between 45 millimeters and 84 millimeters. So, sonographer must obtain optimal image of mid-sagittal plane, which is why you have to see the tip of the nose to prove that you are in the mid-sagittal plane. Embryo must be away from the amniotic membrane with the head in a neutral position, meaning not flexed, not chin tucked, and not hyperextended. Further research by FMF, which is an organization, something maternal, I don't know what this means, we can look that up, has established that we can evaluate the first trimester fetuses for nuchal thickening, presence or absence of a nasal bone, which is another soft marker for trisomy 21 or Down syndrome, tricuspid regurgitation, abnormal flow in the ductus venosus, and possible abnormalities of the hindbrain, which we will learn about later in the semester. But I just looked up FMF, and it means the Fetal Medicine Foundation. Okay. The only thing that I'm going to say about cardiac anomalies is that a 4-chamber view and great vessels can be seen as early as 12 weeks. And serial exams should be done to confirm any suspected abnormal findings. Cranial anomalies can be sonographically identified by 7 weeks. That's crazy to think that. But I guess if you have good enough equipment, then you can. Cerebral hemisphere continues to evolve through the second trimester. This is not on the test, by the way. This is just good to know. And then we had talked about a cystic hygroma, that one image that was next to the nuchal translucency. That is a cystic structure that's seen in the neck. looks like this. Well, it's seen in transverse at the level of the neck. We're going to learn more about that as well. Visualized in the first trimester may vary in size, but all appear on the posterior aspect of the fetal neck and upper thorax. Soft tissue thickening may also be present and should be considered nuchal thickening, not to be confused with the nuchal translucency. We will talk about that when we get to the second and third trimester. Okay, so here's that cystic hygroma. That would be really easy to confuse with amnion. All right, guys, we are coming down to the home stretch. Only about 13 slides to go. Ovarian masses. The corpus luteum cyst is the most common ovarian mass seen in the first trimester of pregnancy. I don't know why it's under the topic of complications, because it is not a complication, but just to remind you, corpus luteum cysts secrete progesterone necessary to preserve the embryo. And a typical corpus luteum cyst measures less than 5 centimeters in diameter and does not contain septations. However, occasionally the corpus luteum cyst grows large, reaching sizes of more than 10 centimeters with internal septations and echogenic debris, which are thought to be secondary to internal hemorrhage. So they grow and they bleed into themselves, and you can see that blood as echogenic debris. Looks like that. This is what we call a hemorrhagic cyst. Kind of looks like spider's web. And doesn't this look just like that ectopic? This is what I was saying. It's sometimes really nerve-wracking, and this is when you really look to see if this is an ovary or if it's adjacent to an ovary. And if it is adjacent to an ovary, you're going to want to put some pressure on it and see if you can separate the two structures. This also has that ring of fire, like we talked about with the ectopic. Color flow imaging may demonstrate a ring of increased vascularity surrounding the corpus luteum, displaying low resistance waveforms on pulsed Doppler imaging. Such findings, similar to decidual flow, characterized in ectopic pregnancies, but are intra-ovarian in location. So that's your key. The key is to look and see if it's located within the ovary. As the pregnancy progresses, corpus luteum cyst regress, typically not seen beyond 16 to 18 weeks gestation. Here's one. Typical corpus luteum cyst within a right ovary at 8 weeks gestation. And this one measures roughly 4 centimeters. Uterine masses. Uterine leiomyomas or fibroids are common throughout pregnancy. They are estrogen dependent and they grow with estrogen. So you can imagine sometimes they will grow with the pregnancy. If fibroids coexist with first trimester pregnancy, they should be identified in relation to the placenta and cervix, because the placenta and the cervix are not going to move, right? So we need to find a place to anchor their location to. Fibroids may increase in size throughout the first trimester and in early second trimester because of estrogen stimulation. A rapid increase in fibroid size may lead to necrosis of the leiomyoma, a degenerating fibroid that may cause significant pain. So that's going to look like fluid within the within the fibroid. Myomectomy, generally avoided during pregnancy due to increased vascularity of uterus and possibility of marked bleeding. So a myomectomy is surgical removal of the fibroid. Rapid growth fibroids may compress gestational sac, causing spontaneous abortion, especially if they are submucosal. Sonographically, fibroids may be hypoechoic, echogenic, isoechoic in relation to the myometrium. Usually they are heterogeneous, typically cause deformity or displacement of the uterus, endometrium, or both. Fibroids are high acoustic attenuators, which gives rise to poor acoustic transmission. Translation, they shadow. They attenuate the sound waves, can't make it to the bottom, and you'll see like shadowing at the bottom. You may not see the posterior border very well. Okay, an 8-centimeter fibroid here, coexisting with a 6-week gestational sac here. The fibroid continued to grow, compressing this young gestation and causing demise. So they're trying to illustrate that there is a fibroid somewhere down here, which can't even see, but you've got this aliasing, which tells us that it's an increased velocity. But the problem that I have with this image, and I don't know whether anybody else has picked up on this, but they've got this color box right over top of the gestational sac. That is a big no-no. We don't put color on the gestational sac. So I wanted to point that out to you. I suppose it's supposed to be down here somewhere, but they should have only put that color box down below, down here. This one's real easy to see, right? Here it is right here. That's a big one too. Well, 6.4 centimeters and 8.2 centimeters. So I guess it's not that big. It just looks big in relationship to the uterus. All right, summary. I am not going to read over these. You can do that, but these are the key pearls in your book. So read over those. That's it. Read over the key pearls, and if you have questions, feel free to let me know, and I will try and post a study guide and images so that you can study the ones that will be on the exam.